feminist organization established in 2022 to track the implementation of the Women, Peace and Security agenda in Africa. I'll start with some housekeeping information. We have French and English interpretation, so click the globe at the bottom of your screen to select your preferred language. We would also like to know who is in the room, so please leave your name, your organization, and the country you're from in the chat box. And lastly, feel free to interact with our speakers, to leave a comment or a question as they speak and as the conversation goes on. We will have time towards the end for more of an interaction. So please go ahead and do that. And again, you're welcome to the discussion. This webinar follows a research study that was done by the Research Without Borders team, examining the impact of conflict and fragility on the sexual and reproductive health and rights of women in Africa, but specifically in Mali, in Niger, in South Sudan, and in Central African Republic. So our discussion today will focus on reflecting on the status of sexual and reproductive health and rights of women and girls in those fragile and conflict-affected countries, with the aim of generating recommendations to improve the protection of their rights. So our goals for the webinar today are: one, to be able to discuss in more detail the impact of conflict on the sexual and reproductive health and rights of women and girls in the countries that we're focusing on, to highlight the legal instruments at national level that promote and protect their sexual and reproductive health and rights, to identify policy implementation gaps and challenges in their access to sexual and reproductive health services, and also to share good practices and actionable recommendations that would contribute to improving the protection of women and girls' sexual and reproductive health and rights in the countries that we're discussing. So Mali, Nigeria, Central African Republic, South Sudan, and Sudan. So you're all welcome. We will start with Latifa Namutebi. Latifa, if you can switch your camera on. Latifa will be sharing the case of Mali and of Central African Republic, highlighting the challenges that women and girls face in access to sexual and reproductive health and rights, and specifically sexual and reproductive health services. She will also highlight the importance of including women in peace building and conflict resolution processes as a means to promote and protect their sexual and reproductive health and rights. Latifa works at Women's International Peace Center, where she's responsible for designing and implementing programs on peace building and women's leadership, as well as conducting research on the experiences of women women in conflict and post-conflict settings. So Latifa, you are welcome.
Thank you, Sandra. Good afternoon. My name is Latifa Namutebi. I work with the Women's International Peace Center, and I will be talking a little about the challenges in accessing sexual and reproductive health and rights services. Focusing on women and girls in Mali and the Central African Republic. So I don't know what you prefer, if you access that. Let me just get to it. So I'll be speaking on the sexual and reproductive health and rights landscape in Mali, some challenges faced by the women and girls in Mali and the Central African Republic. Then I'll talk about women and peace building and conflict resolution. Then why women's involvement matters, the intersection of peace building and the sexual reproductive health and rights. And then I will make my call to action. So I will begin by mentioning that sexual and reproductive health and rights are human rights related to sexuality and reproduction. And currently, both Mali and the Central African Republic are facing ongoing conflict and social political instability, which is impacting the sexual reproductive health and rights of women and girls in these regions. Okay, so in both Mali and the Central African Republic, as a result of a conflict, Healthcare infrastructure, sexual and reproductive health services are lacking. And this is especially impacting women and girls. So some of these services are family planning, maternal health care, and access to safe abortions. So we are looking at the resurgence of the violence and the political instability in Mali of 2012. It led to a deteriorating healthcare system and limited access to the services. And in the case of Central African Republic, the conflict since 2013 has led to the displacement, insecurity, and restricted access to healthcare, with women and girls disproportionately affected. So I want to speak generally on the challenges and then get to each country. So women and girls face numerous barriers in accessing sexual reproductive health and rights services, including poverty, lack of education, cultural taboos, stigmas, and the ongoing conflict I talked about. So medical facilities are destroyed, and the ones that exist are inaccessible because of the insecurity that comes with the movement. We have limitations on women's ability to access contraception as a result, maternal care, and other critical services. So, and we also know that conflict increases gender-based violence and perpetuates negative attitudes towards women's sexuality and making it difficult for women to seek care. So conflict, and as a result of conflict as well, the legal and social frameworks that limit women's control over their bodies, legal and social frameworks limit women and women's control of their bodies because it's not a priority, even when it comes to that. So in the case of Mali, specifically, there have been interruptions in the services that are, a few services that are available. I'll talk about them a bit later. They're deprioritized. And then there is also the cultural barriers that come with that negative attitude and the stigma that I mentioned, and the gender norms that prevent further access. And then in the Central African Republic, there is severe infrastructure damage and prevailing instability. It's made the healthcare just difficult, incredibly difficult. And so there is a fear of violence or abduction on the way to the health centers. And this is preventing the women accessing the health centers. And then, so when we look at, so now I would like to move to women and peace building, conflict resolution. So peace building and conflict resolution involves resolving disputes and fostering peace within communities. And traditionally, women have been excluded from these processes, and it leads to policies and decisions that don't consider their needs and rights. Because at the end of the day, when they are trying to resolve their fighting, they're sharing power, and they're not thinking about the women's needs. And so it's important to involve women in these processes because they bring unique perspectives and skills to peace building, conflict resolution, and they often prioritize social issues like the health and education. And generally, women's involvement brings about more sustainable peace because women usually work to addressing the root causes of any conflict and bring about reconciliation and all that. So another issue is when it comes to women and their organizing, women's groups provide targeted advocacy for women's health and rights, ensuring their needs are addressed. And then there's peace building efforts that include women, also provide economic opportunities that increase women's agency and access to healthcare. And this is in terms of prioritizing and investing in women and their initiatives. So including women in peace building can improve sexual and reproductive health and rights outcomes by ensuring that women's health needs are prioritized, post-conflict recovery plans and policies. So as they are sharing power and all that, the women are also planning for themselves and their needs, and they are able to prioritize that. And so when we look at Mali, increasing the involvement of women will lead to better prioritization of healthcare, because we mentioned it's not prioritized, and the sexual and reproductive health services in the post-conflict recovery, and this will contribute to improved health outcomes. Same as Central African Republic, it will ensure that safety measures are put in place for women seeking healthcare, and so it will encourage more women to access their services, sexual and reproductive health services. And I want to mention some of the services that exist in the Central African Republic and also in Mali. So for example, we have the government, which has hello? I think I'm still on. I hope.
Yes, you are. You are on.
Oh, thank you. So we have government which is working to provide family planning services and emergency contraceptive services to women and girls, and working with regional, national, international organizations to provide services. And then we also have, sorry. Yes. So I think that is it on the surface. If I raised any questions, I will wait to address them. But for now, we have Medicine Sans Frontiers, UNFPA, and other organizations that are working to provide, some of them provide obstetric care, family planning, and this is mostly medical camps, because they are really going out of their way to reach out to the people, because they understand the limitations with movement and the insecurity and all that. So I would say that if we support local women's organizations and strengthen advocacy on women's involvement in peace building, and we'll be able to invest in healthcare infrastructure and sexual reproductive health services, and this will, in the long run, will be promoting gender equality and women's rights and education. And so I'll just say, I'll conclude by saying that in conflict-affected regions like Mali and Central African Republic, addressing the challenges in accessing sexual reproductive health and rights services and promoting women's involvement in peace building is crucial for improving health outcomes and promoting peace and equity. Thank you.
Thank you, Latifa. We'll now move on to Sudan, again focusing on the challenges women and girls facing accessing sexual and reproductive health services, but also hearing about the importance of data collection and monitoring and being able to track progress, and how improved data systems and analysis to inform evidence-based policies and programs can contribute to solving challenges related to sexual and reproductive health status of women and girls in Sudan. We will hear from Dr. Rabab Baldo on the case of Sudan. Dr. Rabab Baldo is a mediator, the former senior gender advisor to IGAD Special Envoy for South Sudan at UN Women. She has also served as the Gender and Elections Governance Advisor at UNDP in Tunisia. So Dr. Rabab, you are welcome. Please turn your video on and we'll hear from you.
Good afternoon. Thank you, Sandra, and thank you for the other panelists, and thank you for those who are with us to hear the story of our countries with regard to the sexual and health reproductive issues, related issues. I have to say Sudan has used to have policies related to sexual and reproductive health, but unfortunately, because of the war that erupted in on the 15th of April, has really took us back. There is no functional government as we speak. There is no system that is work. The whole country and all the system collapsed. The issues of war-related sexual gender-based violence is increasing and is becoming alarming. We have so far reported cases in 1 week, 24 cases. We know very well the number is more than that, but unfortunately, we don't have a mechanism to verify those numbers simply because of the mobility issue, the gunfire all over the places. And again, due to the social stigma, most of the survivors, they don't want to report. And again, also the fear that they are into it. They don't want to report if, so that they will be targeted or politically assassinated by either the Janjaweed or the military. The other also chronic issue of related to sexual reproductive health is the issue of the female genital mutilization, and I'm sure most of you are aware that Sudan is one of the countries is still practicing, and despite the fact that there is a law banning FGM since 1948, but this law has never been put into practice because of the social resistance of the families. And again, it's a source of income for the pairs, for the midwives and the doctors. So people tend to take their daughters to their own villages outside of cities and practice female genital mutilization at that level. There is no monitoring mechanism in place. The law banned it, but there is no very clear monitoring process to ensure that really the health workers and the doctors are not really practicing at that level. So as we speak now, the priority for us with regard to the reproductive health are three major issues. One, related to really addressing the sexual gender-based violent conflict-related SGBV and help those survivors to really seek medical support. In some cases, we managed to identify doctors near in the neighborhood so that the survivors will not be exposed to the gunfires and try to really protect them in their journey to seek, support and address their health issue. The second thing also, for those who are pregnant, because as I speak right now, 112 hospitals are out of services. Yes, there is the peace agreement that was signed 2 days ago, and it has ceasefire in certain areas, but not the rest of the country. Still, the gunfire is there. Still, the two generals are not respecting and are not really ceasing fire in most of the areas. So it's still the issue of helping the pregnant mothers to really seek a safe, birth attended or safe delivery, as we say, is an issue. Most of them has really faced difficulties, especially if there is no midwife around, imagine traditional birth attendants around to help them, or if they are in the remote areas and then they cannot really move to really reach any point that doctors are volunteering to provide support. So the situation is really very tense on the ground, and it's a tragedy that now the safety and security of the people becoming an issue, let alone the sexual and reproductive health related issues. So this is what I want to share, and if there is any question, I can elaborate later. Once again, thank you, Sandra and the team, for this opportunity, and ready for any question.
Thank you, Dr. Rabab. We'll open up to the room to ask questions. Please, if you have any questions, leave them in the Q&A section or in the chat. But otherwise, we will have a moment towards the end to have a discussion and to pass on any questions that the room has for the speakers. So we'll now hear the case of South Sudan. For that, we have Sarah Abeja, who will talk about the impact of displacement and living in refugee situations on the sexual and reproductive health and rights of women and girls, particularly as well on the challenges of implementing legal instruments on sexual and reproductive health and rights in South Sudan. Sarah, you're welcome. Please put your video on. So Sarah Abeja is the country coordinator for the South Sudan program at Women's International Peace Center. She also represents women's groups on the board of the Ceasefire and Transitional Security Arrangements Monitoring and Verification Mechanism, CITISAM, which is the body that's responsible for monitoring compliance with the peace agreement signed in 2018 in South Sudan. So over to you, Sarah.
Thank you so much. And thank you so much for the other panelists who have discussed so far. As mentioned, I'm called Sarah. I'm based here in South Sudan, Juba. I'll just be discussing a few issues, especially the impact of displacement on sexual and reproductive health and rights. Looking at the context of sexual and reproductive health and rights, I will be referring to the definition of the International Conference on Population and Development, which indicates that it's a state of physically, emotionally, mental, and social well-being in relation to the aspects of sexuality and reproduction, and not just merely the absence of disease or infirmities. Now, when you look at this, what constitutes sexual and reproductive health rights, it makes me think that in South Sudan, as a woman, we are really very far from achieving what we refer to as sexual and reproductive health rights. First of all, the displacement in South Sudan has been caused by conflict, but also as a result of climate change. Looking at the strategy of reproductive health, the South Sudan Reproductive Health Strategy, the key interventions that are stipulated there are family planning, safe abortion to the full extent of the law, post-abortion care, pregnancy and child care, including emergency obstetric care, postnatal care, prevention and management of sexually transmitted infections such as HIV, especially prevention of mother-to-child transmission. So those are the dreams that we have in the strategy. However, this strategy practically is in paper. That's what I can say. We developed a very nice strategy that if one would read from afar would think that, oh, the women of South Sudan are really taken care of. However, with the current displacement caused by war and also flooding, you find that this strategy, we look at it and say it's a dream, because there is inadequate sexual reproductive health delivery, especially now that we are facing in this humanitarian setting, we have women who are displaced and living in the IDP camps, and in these IDP camps, there is a very, very minimal access to sexual reproductive health services. The reason for this is, first, the system that normally provided for reproductive health services got weakened, got destroyed. Some facilities got looted, and most of them are currently occupied by the military, like the military occupying the health centers. Although CITISAM has urged both parties to demilitarize and evacuate the civilian property, that includes the hospitals, it has never been respected. In a few places it has, but in most cases, these places are still being occupied. The other issue is the victims, once they get displaced, for those who used to live in the areas previously that were having these services, once they got displaced, they had now limited access to finances, materials, they suffer from stigma, there's discrimination because they are going to a new place, even information on their rights, they don't know. These displaced people also, they lack knowledge of the area, and the fear of even moving out of the camp really affects women. And then the other issue that affects the provision of reproductive health services in a conflict setting, especially in displacement, is where the humanitarian actors begin to prioritize, and then reproductive services are not given priority. Even if they look at health in reproductive health services, they may only look at the issues of antenatal and then providing the women with a safe delivery space. But these other aspects like family planning and all that, they're not prioritized, leaving a lot of gaps. These gaps are even greater among young women and girls, because young girls face greater levels of gender-based violence. Some of them even end up with unsafe abortions, because some of them, once they get raped or even they get teenage pregnancies, they just decide to do unsafe abortion, which leads to actually, it is the leading cause of female morbidity and mortality. Indeed, women and girls in humanitarian settings continue to be deprived of basic sexual and reproductive health services, resulting in devastating consequences. The challenges that we face, especially looking at the legal instruments in South Sudan. Women, for those who get displaced and find themselves in the refugee camps, those countries that they found themselves in, like for instance in Uganda, those who got displaced to Uganda, those who went to Kenya, Ethiopia, they were able to benefit from the services that were available in those countries. However, those who remained in country as internally displaced persons faced greater challenges. Why? Because the country itself had gone through a long period of war before separating from the Sudan. Now, when we got the independence, we thought that we'll sit down and have laws that we should develop laws that would protect the people. But before even we could complete with the constitutional review process, we went back to war. So with this, there are no legal instruments to protect women, even in normal situation, let alone during displacement. Rule of law no longer works in our system of South Sudan when there is a conflict or flooding and people get displaced. People don't, impunity is at its highest. Also during the time of displacement in a country like South Sudan, which already had very poor infrastructure, humanitarian actors now prioritize food, water, basic shelter, and general medication, while the reproductive health services are relegated. And even the service provider, the actors, the humanitarian actors, don't follow these policies because now they have to set priorities of priorities. Looking at also our situation, South Sudan, the conflict in South Sudan has been accompanied with impunity. So conflict-related sexual violence gets so politicized. So even advocating for sexual and reproductive health services, you will be mistaken to be trying to accuse the military or those who in authority that women are not protected, looking at the issues of high levels of rape, the issues of child marriage, the issues of HIV, because right now the prevalence of HIV is also high due to the impact of this conflict-related sexual violence. So, and the services were not availed to the women, post-exposure prophylaxis. A lot is really happening. So it's worse even in displacement, because now looking at the issues of poor adherence to rule of law, you find that this, whatever even is in place, like the policies and the strategies, don't work. And for us who try to advocate for this, we are mistaken to be trying to accuse the government or the soldiers for raping women. So the whole thing is really politicized. So with this, you find that it's really challenging to look at the issues of the legal instruments. However, with this implementation of the agreement, we are seeing that the government currently is beginning to become very positive on the issues of women and reproductive health. One of those key things that are being discussed in the transitional justice processes that the country is going to enter into, making sure that the demands and the needs of women to be considered. And what are the demands and the needs of women health-wise? Our priorities will be looking at the issues of sexual and reproductive health. The other challenge we're also facing is there are laws like criminalizing HIV, they call it infection. So you find that even people fear to go and test in a situation whereby we have polygamy. So then if I test first, I'm considered to be the one who brought the infection into the marriage. So I can be taken, I can be arrested for, they call it intentional infection. So you find sometimes women even fear to go and test for HIV. And even when they test, they fear to adhere to medication. Then looking at the issues of condom use, when you're born with condoms, it's like you are encouraging immorality. And then also services like contraceptives. As a woman, I have to go with my husband. Now, what happens to the young lady or a lady who is not officially married? There is no man to accompany her to go and get these contraceptives. It becomes really a challenge. We meet the issues of tradition and the legal. So these practices, even in the hospitals, they follow them. You go, you want to get contraceptives, you have to go with your husband, and he has to sign a document to show that for sure he has allowed you to take contraceptives. Don't stay with us. Some of them live somewhere and the woman is living somewhere. So you want this, you cannot get. It's even worse for these young girls because we have teenage pregnancies and these girls go for unsafe abortion, because even abortion is a crime in this country. So you get pregnant, you keep the baby, and if you don't want to keep the baby, you end up, like the young girls end up doing these unsafe abortions. So basically, Looking at the legal instruments we have on sexual reproductive health rights, we have a minimum, but those even who are present, which are present, don't support us as women. Like age of consent for a young girl, even to, not a young girl, for teenagers to go and have maybe HIV test. They can't go and do that. So the laws that we have themselves are also a challenge to the young people, but also the practice affects a woman, because if your husband is not there, then it means if he doesn't even abide the idea of contraceptive, because there are also negative connotations that people here have over contraceptive. So some men begin to believe in those beliefs, and they will not allow the woman to go for sexual reproductive health services. So that's the little I would have loved to share with us. Thank you.
Thank you, Sarah. We will now hear the case of Nigeria. Queen Etawo will share the initiatives, the successful initiatives that have been able to improve women and girls' access to sexual and reproductive health services, and lessons that have been learned from implementing them, and gaps that still remain in provision of sexual and reproductive health services for women and girls. So Queen Etawo is the regional coordinator for Women, Peace and Security at the West Africa Network for Peace Building, which is WANEP. She oversees the Women, Peace and Security Program activities at the regional office and provides support to the 15 WANEP national networks in West Africa. Queen, you're welcome.
Okay, thank you very much, Sandra. And it was really a challenge for me being able to join, because I am actually in another seminar with ECOWAS. I completely did not see the emails that this meeting has been moved back to the 24th. And even today, I tried severally to join, only to discover that all those emails were going into my spam folder. That was how come I never saw all these things. In fact, I was actually thinking this meeting was going to be on the 30th, because right now we're having the ECOWAS meeting, which is physical. So I'm trying to hide in one lounge to see if I can be able to speak a little about what is happening. So I'm really very sorry. And it was even just yesterday, actually, that my communication person drew my attention to the poster. So like I said, everything was in the spam folder. However, because my internet is also fluctuating, I want to crave your indulgence to please off the video and while I make my presentation. Now, one of the challenges when you speak after so many experts have spoken is the fact that some of the things you have actually wanted to touch on has already been touched on and expanded. So not particularly talking about Nigeria, but also talking generally about some of the, because one for us, we work in the 15 ECOWAS member countries. And one of the things we have discovered is that what happens in one context actually happens in the other context with very little differences. So the health issue, the sexual and reproductive health issues that you might find in Nigeria, you actually can find it in Ghana. And you can also find it in other aspects of, in other parts of West Africa. And I'm hearing the people from South Sudan talking about it, and it is still the same issues that we are battling with. I want to just stand on the definition of the International Conference on Population and Development, which says that human rights of women, who sees the women's human rights as their right to have control over and decide freely and responsibly on matters related to their sexuality, free of coercion, discrimination, and violence. So that, in a nutshell, captures what this whole sexual and reproductive health issues is talking about. But of course, we do know that that is the definition, but that is not the actuality. Women do not have unhindered access to a whole range of health facilities. Women do not have access to even safe potable water and sanitation and nutrition. There are a lot of factors that hinder them. I do see I read somewhere that about 4.3 million sexually active persons persons, not just even the women, worldwide, who will receive poor or limited access to sexual and reproductive health services in their lifetime. And this is the reality that we cannot afford to, to overlook. It is a given that women's sexual rights and their reproductive health is actually impacted negatively during wars and conflicts. It has been established here. The previous speakers have also, set this, have brought up this issue, that crises result from both disasters and war, man-made, famine, pandemics, and all that have a grave impact on women's sexual and reproductive health. Because during those crises, when the environment is not stable, of course, we do know that there will be very limited access to health services. The information that women will need to access their sexual and reproductive health services will not be there because this country is at war. There's a lot of safety. People are looking for ways to be safe. There's a lot of funding that should have gone for health services for women that is now being redirected to other services to even help saving lives in that time. As at that time, nobody's going to talk about all these issues. And we do know what happens even in the aftermath of war. So women's rights to health and reproductive health is not only impeded during war, even at peace, so-called peacetime, it is also impeded. Now, we have heard of situations in Nigeria, for instance, where the militants in Nigeria actually, impact on the women's health. It is said that Boko Haram militants actually impose abortions and contraceptive use on women. They even enforce marriages. Some of those women and girls that they forcefully adopt, they forcefully marry them off. So and those women are sometimes raped. And of course, when they come back, when they manage to come back into the society, they are stigmatized. Their children are not even accepted. So where do they even begin to think about or to demand access to health services when they themselves are even being discriminated against? So these are some of the issues that happen. Pandemics have a lot of impact on women's sexual and reproductive health. During Ebola, during COVID-19, all these issues about women accessing health services was not there. Why? Because there was limited access, there was lockdown, there was restriction, there was social distancing. And when you put this also in the context of the fact that women ordinarily were not even exposed to all these services, this is the former, this is now the former exacerbated due to the pandemics. We do know, and in Nigeria, there are statistics to show that actually during the lockdown of COVID-19, issues of gender-based violence escalated. I do know that there are some debates saying, oh, what was the parameter to prove that it actually escalated? UN Women has done a lot in this aspect to show that, yes, indeed, when women were locked down with the abusers during the COVID-19 era, what happens? They are on a daily basis exposed to this gender-based violence. Someone has talked about policies and legal frameworks. We do know that the United Nations, the SDG goals and the MDG goals, especially 4 and 5, has already situated maternal health as a global priority. But it is one thing for it to be there, it is another thing for it to be implemented. And not just to be implemented, but to be adequately implemented. The WPS agenda, the whole gamut of the WPS agenda, 1325, and all the other related resolutions stresses sexual and reproductive health assistance for survivors of sexual violence. But oftentimes, all these things are in paper. All these things are not really practicalized. We talk about what happens in the IDPs. When women refugees, because all these wars and conflicts, what do? They deepened they increase the number of internally displaced persons. They increase the number of refugees. And we have known that women form the bulk of the IDPs. They also form the bulk of refugees, either migrants, either they go to other countries, or they even remain internal refugees in their own countries. Women still form the bulk of that. And we also know that relief and recovery materials hardly take into consideration the peculiar needs of the women and girls. So when they are doing humanitarian assistance, to what extent do they factor in the peculiar needs of the women and girls in those IDP camps? All these are factors that hinder women from achieving their full potential in accessing health services. I do heard one of the speakers talk about the fact that IDPs, they are exposed to all these numerous health challenges. They are also exposed to rape, which of course results to them contracting terminal diseases or sexually transmitted diseases such as HIV and AIDS. It is also exposes them to unplanned pregnancies. It exposes them to other very serious health challenges. And we have evidence to prove that women who have been in IDPs have also suffered from the PTSD, the post-traumatic syndrome disorder, because of some of the things that they experience there. But I want to go straight. I don't even also want to talk about all the factors that continue to deepen women's inaccessibility to health, such as social cultural factors. Somebody has said that. But I want to mention specifically that even in some cultural practices in Nigeria, there is this practice that is surrounding pregnancy and childbirth. I don't want to mention any tribe, but I do know that there are some tribes that women cannot even go to the social welfare centers to go and give birth. So cultural practices enforce them to stay at home to give birth. I've heard of cultures and traditions where a pregnant woman is not supposed to shout or cry when she's giving birth, and so they die in silence. I've also heard even the way the childbirth, the way that the pregnant women are treated during after childbirth is even a factor. We do know that it is not easy to access sexual health services because of our culture and customs. Like somebody said, you have to go to, if you want family planning service, you have to go with your husband. But even in Nigeria, there was a time we're even battling with the name family planning. Should it be called family planning? Because of the way people perceive family planning, that it is a Western idea of curtailing the number of children that you have. So we battle with the idea of calling it child spacing and family life education and all that. So these are some of the challenges that make that we cannot even talk about sex education in schools because of the cultural connotation and things like that. So these are factors that are real and things that we really need to take into consideration when we're advocating for increasing access to women, for women to access sexual and reproductive health services. So I just want to, since my time is limited, let me just talk about a few recommendations, because like I said, other experts have enumerated all the problems and the challenges and all that. So I want to dwell more on some of the solutions, so to speak, or some of the things that we can do that can actually ease or help us to solve these problems. So I've talked about having a multi-sectoral collaboration. When we are talking about assessing health, there are a lot of partners, a lot of stakeholders that are at stake here. And sometimes government comes with just a one-cap-fits-all approach, and it is not even sustainable. That is why you go to hospitals, for instance, you cannot see drugs because money, health services, just like gender issues, they do not really deliberately, budget for it. So even in the health budget, how much of that budget is dedicated to women's services and all the issues that women go through in the sexual and reproductive health? So we need to partner with like partners. There are some international organizations that are health focused and also civil society organizations that are health focused. At least through them, women can be able to access all these services that they cannot get with their national governments. But more than anything, we have to recognize that sexual and reproductive health rights are actually a woman's basic human rights, and it should not be violated. So we need to advocate as civil society to the lawmakers, to the government of the day, to ensure that these rights are not violated. So even as we fight for women basic human rights, we should also fight for these women's sexual and reproductive health rights. So we should factor it into humanitarian assistance. Like I said, there should be a deliberate attempt to ensure that in providing humanitarian assistance, there should be focus on how to ensure that women, that they have access to knowledge about family planning, that they have access to shelter in terms of gender-based violence, and that the basic needs of the things that they need during their time in the shelter should be provided, like sanitary towels, for instance, for girls, and also that they should be protected even while they are there. So we need a lot of awareness raising in order to ensure that their reproductive health and rights issues are factored into humanitarian assistance. We need to provide safe spaces for victims of gender-based violence. Government in Nigeria, don't think we have any government-run shelter, but we do have individuals. We have civil society, like Project Alert, for instance. They have shelter for domestic violence victims. And I do know that there are some other organizations also where they have counseling services, trauma, stress counseling, and all that, to ensure that the women or the victims of domestic violence have a safe space so that they can take back their lives. So health education is very, very important. Promotion of healthy lifestyle. I have talked about sexuality education and family planning being a taboo subject in Nigeria. But there are ways that we can go about it. For instance, talking about lifeline education, for instance. Lifeline education. There should be counseling centers where clients can access sexuality information anonymously. Because this idea of that you have to go with a husband for you to be able to access like family planning services is not good. So, and then when we as NGOs, we're also calling for support to maintain long-term relationship with health service providers. Some donor agencies have helped national government to develop a sector plan, just as it happened in Liberia and even in Guinea in the post-Ebola era. I think this is a good practice that when we as NGOs, when we are trying to, ensure the women's sexual and reproductive rights, we have to work with these development organizations so that we can develop health sector plan for the nation. So for me to end, I want to say that it is worthy to know that wars impede access to maternal health care, but this can be reversed by targeted interventions focused on increasing access to and availability of healthcare services. So thank you very much.
Thank you very much, Quine. And thank you to all our speakers, and thank you to the people that have been here for the past 50 minutes. So now we open the floor to others in the room to ask any questions, make any contributions. I'll start with Patricia, who had her hand up, and then go to Bahati, but anybody else, please put your hand up and, ask a question or make a contribution. So Patricia, over to you.
Bonjour tout le monde, bonjour. Je suis Patricia Chouma de la République démocratique du Congo. J'aimerais savoir quels sont le mécanisme que vous proposez face à ce que subit la femme dans plusieurs pays dont nous voyons sur les systèmes de planning familial, le système de manque de soins et tout ce qui va avec. Merci.
Thank you, Patricia. Bahati?
Hello, can you hear me, please?
Yes, go ahead.
Okay, so thank you so much for the panelists. I will try to speak in French. I think the translation will help me reaching. I would like to raise two issues. Donc, je voudrais revenir sur les petits éléments. Et le premier élément, c'est que dans le contexte de la République démocratique du Congo, le sexe est un tabou. Donc, on ne peut pas parler du sexe de façon facile, permettre aux filles et aux femmes de parler publiquement à la radio, dans des espaces publics. Donc, ce n'est vraiment pas quelque chose de très aisé quand on parle du sexe. Donc, lorsqu'une femme, lorsqu'une fille essaie de revenir sur toutes les questions relatives au sexe, en tout cas, il y a une certaine stigmatisation que l'ancien son encontre et n'est pas vraiment bienvenue. Ça, c'est le premier élément. Le deuxième élément, c'est que le contexte de la République démocratique du Congo, il y a des zones qui ne sont pas du tout accessibles par la connexion Internet, par les téléphones mobiles. Donc, il y a donc de façon difficile que les gens comprennent, même ici à Kinshasa où je me retrouve, ou dans les villes, les gens ont des difficultés, n'est-ce pas, de se connecter. J'ai déjà au moins 4 personnes qui m'ont dit qu'ils auraient bien voulu participer à cette réunion, mais ils ont eu des difficultés de se connecter. Alors, comment à un grand nombre, ça c'est vraiment une préoccupation, dans des zones les plus reculées, dans des territoires, dans des villages. Et ces questions va aussi dans des zones occupées par des conflits armés. Il y a cette question des femmes victimes de violences sexuelles et celles basées sur le genre, qui ont des difficultés d'accéder même aux soins de santé parce qu'elles sont dans des zones contrôlées par les groupes armés, où il n'y a pas de hôpitaux, il n'y a pas de connexion. Les femmes qui n'ont même pas de téléphone, les femmes qui ne connaissent même pas lire et écrire. Hein? Comment ces femmes-là peuvent franchement arriver à
Bahati, we are not hearing you anymore. Maybe you can leave the rest of your submission in the chat. Do we have anybody else?
remettre parce que même la femme qui est dans les...
Continue.
Sorry?
Sorry, continue. We didn't hear the last bit. Your connection was on and off.
Okay, thank you so much. So I was finalizing saying that je suis en train de proposer qu'on puisse franchement définir des mécanismes de communication efficaces qui permettent d'atteindre cette femme-là qui est dans un milieu le plus reculé, cette femme-là qui ne connaît pas lire. Donc, comment on peut faire pour que le message important que nous sommes en train de dire, que nous sommes en train de vouloir, que les...
Thank you, Bahati. I'll read one more question that Helen left and then go back to the panelists while we wait for more from the room. So her question was, for all the panelists, what can civil society organizations and women human rights defenders do to promote the sexual and reproductive health rights of women in your context? So with those questions, I'll go back to the panelists. We have the one from Patricia asking for what your recommendations are in terms of strengthening the mechanisms that can ensure better access to, she specified family planning, but perhaps, yeah, well, let's focus on family planning. The second one was from Bahati about solutions for ensuring access to information, particularly for women who are in rural areas, who are not able to read and write, and for those who are in conflict-affected zones. And then we have the last one from Helen about what specifically CSOs and women human rights defenders can do to be able to promote the SRHR of women in their context. So whichever panelist wants to go first, please unmute. Or we can start in order. Latifa, do you want to start us off? And then, oh, Sarah, go ahead, Sarah. I see you're unmuted.
Okay, thank you. I'm going to start with the question from Helen. That what can the human rights defenders do to promote sexual and reproductive health rights?
Please go ahead.
I think what we can do as what the human rights defenders can do, first of all, like here in South Sudan, is to advocate for the change in the practices, especially these laws that affecting women, maybe repealing the aspects of criminalizing HIV infection, and also looking into having sexual and reproductive health law that will guide how the issue of sexual and reproductive health will be handled in the country. Because currently, when we try to talk to the service providers, they feel like that is the practice, and we don't have a basis to ask them to open up the space for women to access reproductive health services without going through those barriers. The other thing that maybe would want the human rights defenders to do would be creating awareness on the importance of reproductive health rights, and especially at the local level, but also looking into the issues to do with the barriers that deter women from accessing these services. Because also we've seen in places where the services are available, but there are a lot of barriers that can make us not to get those services. So for me, I would encourage awareness. And then maybe the other thing, especially for the young adolescents and girls, the comprehensive sexuality education program should be something that the human rights defenders should really push for, because the government of South Sudan signed the ESA commitment, the Eastern and Central Africa commitment on comprehensive sexuality education. Now that the government has committed to that, I think it would be good for us as women rights defenders to take opportunity and push for the laws that are looking at the consent, the age for consent for the young people, such that we reduce the numbers of death from unsafe abortions and the like. So maybe that's what I would have asked from the human rights defenders. Thank you.
Thank you, Sarah. Latifa, you can go ahead. You were unmuted earlier.
Thank you, Sandra. So I'll begin with the question, what can CSOs and women human rights defenders do to promote the sexual and reproductive health and rights of women in your context? So I'll begin by saying that we have to strengthen legislation. For example, in the Central African Republic, the current laws don't explicitly prohibit child marriage, and the penalties for sexual violence are not severe enough to deter continuous violence against women. So the CSOs and women human rights defenders can prepare campaigns, advocacy campaigns to target policy implementation in these areas. For example, still Central African Republic, the National Strategy for the Promotion of Gender Equality and Empowerment of Women, it acknowledges the need for improving, is a framework which can be targeted, because it acknowledges the need to improve access to the services, but there's no plan to implement, there's no budgeting, nothing. It's just there. So that's a very good opportunity for civil society and women human rights defenders to target. And from here, they can talk about the laws on, for example, I mentioned the prohibition of child marriage and also the penalties, and ask for revision of those laws, so that's an implementation. And then in Mali, so while the laws in Mali provide a foundation for protection of sexual reproductive health rights, the regulation, for example, regulating traditional birth attendants, it's the implement really like law. So civil society and women human rights defenders can work towards promoting the use of skilled birth attendants, and also a continuation of that is providing comprehensive information and sexual and reproductive health information and education to the women, and this can be done by utilizing. So I think this ties also to the question: how do we make sure that women who don't have to access to information get it? We go to them. We use their resources or infrastructure that they have. For example, I know that at community level, people rely a lot on community dialogue. So they have community centers, community meetings, those kind of spaces where we can come join. We use radio talk shows. So that's how we can do, so that's where we can do our campaign to provide education, and also civil society can provide training to healthcare professionals, and also provide maybe clinics and facilities, equipped clinics and staff who are trained. Because this is one of the biggest issues in Central African Republic and Mali, is that there's limited infrastructure, but the existing infrastructure has unequipped labor. So then there's also in Mali, the rural people in the rural areas are really like neglected. So there's intentional reaching out to the health care centers to keep these healthcare workers, but also going to these people. For example, Association for the Development, Ela Sante, family planning, prenatal, postnatal, emergency, and so it's just about working together with them to be able to broaden their work, upscale it, and be able to go to these people in the communities. And then also CSOs can fund government agencies that works towards sexual reproductive health and rights outcomes for women. I hope I've answered all the 3 questions in a way.
Thank you, Latifa.
Thank you.
Thank you, Latifa. Let's hear from Dr. Bab.
Thank you. Okay. The point I would like to highlight is the reproductive health in conflict and in war. This is an area we need to have to build our capacities as a civil society and women human rights defenders. In a situation where there is a high mortality rate among women and children because of the deaths, because of the direct shooting and gunfire all over, in a situation that access to health services and reproductive health services is already restricted because the mobility issue. Again, most of the hospitals are occupied, as Sarah had mentioned, by military or armed groups. Third, also the availability of the staff, the health staff and doctors at those places. The other point also, as civil society and women human rights defenders, is really to advocate to ensure that reproductive health is one of the priorities that will be considered when humanitarian support will be provided. It's not the issue of shelter, it's not the issue of water, it's not the issue of food and basic needs, but also the women human rights also priorities that need to be considered. We need to also find a way to strengthen our ability as civil society and human rights defender in working in a conflict situation to address the women human rights, reproductive and sexual health. I have talked about many cases of rape happening, but unfortunately we're handicapped, to provide a kind of support for the survivors because we cannot reach them. We cannot really reach them. The other area also, ensuring a clean environment, because as we speak, and maybe the last 2 days, yesterday, in fact, ICRC managed to clear the dead body from the street of Khartoum. And still some areas are having this, and some of them are pregnant women, some of them are children. So those are the issues that we have to really brainstorm and think outside the box on how we can address these issues. And thanks for really creating this webinar so that people really need to think to consider how best we can provide support in unstable and in war and conflict situation.
Thank you, Dr. Bab. Pauline, can I invite you to share Queenet's submission?
Okay, so Queeneth is saying that as civil society, we can mainstream gender in humanitarian programs. We can create visibility and awareness on sexual and reproductive health services, referral systems, and shelters. And we can advocate to the powers that be to implement laws and normative frameworks they've assigned to situate women's reproductive health issues as a global concern. Information can also be in local languages. And then she also wanted to emphasize a multi-sectoral approach, that CSOs should not work in silos, but should find areas of convergence so that they can be able to accommodate more interventions towards improving women's access to reproductive health services. Yeah.
Thank you, Pauline. Thank you, Pauline. We also have another comment from Ezabir. I don't know if you want to share it yourself, Ezabir, or I can read it as well because it's in the.
Okay. Yeah. Hi. Thank you.
Hi. Go ahead.
Yeah, I just wanted to say thank you, everyone. It was wonderful presentations by all the panelists. I am joining from Kashmir, from the Indian administered part of Kashmir, and my name is Izabir Ali. I am an alumna of the Peace Institute. I wanted to share that, I connect with most of the sharings by the panelists. I have witnessed it all in Kashmir. So what you shared is not very uncommon in the part of the world where I come from. But I feel that, though you have given much food for thought, I feel that, if we work on the mindset of the population at large, I feel that it will help free women and the population at large by the constraints of the traditional patriarchy. And I know it's not an easy task when you talk about changing the mindset of the population. It's not easy. It's easier said than done. But then when you talk about reaching out to the women in the rural areas, and how you can help them access, and to have information, I think IEC plays a very important role over there. IEC is information, education, and communication, and you can tailor it as per the need of your local requirement. You can use local languages, you can use, street plays and all to reach out and make it easier for these women to understand what you're trying to, the messages that you're getting across to them. And sometimes using very creative ways helps to convey the message, deep down. I think, that has proven very successful in Kashmir, and I wanted to share this experience with you all. Thank you so much.
Thank you, thank you, Azabir, and thank you for joining from Kashmir. I don't see any hands up, so my assumption is that all the questions that have to be asked have been asked, and we've been able to hear some really strong recommendations about what needs to happen moving forward, where we need to place our attention, what some specific steps are. And I want to point your attention towards the chat. You'll see that Researchers Without Borders has shared a copy of the policy brief that was developed following the research that was done, focused on the countries mentioned. So Mali, Central African Republic, Nigeria, South Sudan, Sudan, and Ethiopia. So if you can go to the chat, you'll get the link, and please, read through the brief, make any contributions directly to Researchers Without Borders. And thank you all for making time to join the webinar. I see we have one. Okay, yes. Thank you all for making time to join the webinar, for sharing your reflections. Thank you to our panelists, to Dr. Rabab, to Sarah, Latifa, Gwyneth. Thank you for making the time, for sharing your insights. And thank you all for joining the discussion, for also sharing your insights. And we look forward to engaging with you further on the findings of the research and on the policy brief, in seeing how to move forward the recommendations and how to translate them into actual changes in terms of the status of women and girls' sexual and reproductive health and rights in fragile and conflict affected countries. So have a good afternoon and stay in touch. You have a copy of the policy brief in the chat.
Thank you, Sandra, for an excellent mediation or moderating this session.
Thank you.